Okay, good morning, and thank you all for joining us today. I'm a moderator for this session, Teppei Sugaya from Japan. This session is a challenging case presentation for. Today we have six presenters. Last presenter is cancelled. And we have the six presenters and four panelists. Please briefly introduce yourself. Dr. Dean?
Yes. Yes. Good morning. Yes, I'm Dean from Vietnam. I'm working from in Ho Chi Minh City. Yeah.
Thank you. Dr. Fang?
Good morning. Thank you.
I'm Dr. Fang. I'm originally from Hong Kong, Queen Mary Hospital. I'm currently with the Brigham and Women's Hospital in USA as an interventional fellow.
Okay. Dr. Kwok?
Good morning, everyone. I'm Kevin. I'm coming from Hong Kong and now in private practice.
Okay, thank you. And then Dr. Park. Yeah. Okay. First presentation is from Malaysia. Presentation title is Hanging by a Thread, a challenging case of the acute coronary syndrome caused by critical stenosis distal left main and critical stenosis right coronary artery due to relatively calcified nodule in an octogenarian patient.
Thank you very much. Good morning to the moderators as well as the panelists and everyone gathered here. My name is Dr. Lee and I'm from the National Heart Institute in Malaysia. It's a pleasure to see you all here and share with you this case. It's my disclosures. So a bit of background about this 88-year-old gentleman who was rather fit and still ADL independent with background hypertension and presents with typical crushing chest pain with radiation to the jaw. The ECG did show minimal ST depressions in the inferior leads, but the echo showed a good ejection fraction with preserved wall motion function. So I go straight into the angiogram, and this is what we saw on the right coronary artery angiogram. So quite a sizable right, but you can see there's a sort of like a filling defect in the center. This is the left side, and you can see the terror that is faced by us. There's a very tight stenosis in the distal left main caused by a calcified lesion, and even before the opacification with contrast, you can see how much calcium there is everywhere. And to make matters worse, in the cranial view, you can actually see a couple of aneurysms sitting in the distal LAD as well as the proximal circumflex vessel. So what would be the strategy in this situation? Obviously, with 3 vessel disease, heavily calcified lesions, bypass was offered. However, I doubt many of us would want to go for bypass at the age of 88 years old. Furthermore, 2 surgeons also turned down the case due to his age. Now, what about PCI? A syntax score of 50 would have definitely said that based on the syntax score, bypass was superior, but patient refused, surgeon also refused, so we had to take up the case. So we decided to go with all guns blazing. We decided to do the right coronary artery first with a TPM as we were prepared with arterectomy. So it's actually clearly a calcified lesion. We use IVUS to confirm. We use a rota, this is a 1.5 burr, a few runs, following which we put in, I think, two long DES stents. But the highlight of the case I want to share with you is the PCI to the left system, which we plan to do a rotablation and OCT. The strategy was with a 7 French EBU guide, as atherectomy was quite likely mandatory, and we used OCT as a mode of coronary imaging given the heavy burden of calcium. Now, the concerns that we have leading up to the case was, can the OCT catheter pass at all? Would it get stuck? And if it passes, would it cause flow obstruction? And a flow obstruction in distal left main in an 80-year-old gentleman is probably will be catastrophic with no turning back. So we decided to balloon first with a 2.0 NC to create a channel and sort of palpate the vessel and see how it responds. So this was the stage procedure, which was done 1 week later. You can see the tight distal left main lesion still there, heavy amounts of calcium. The couple of diagonals have already been lost due to prolonged disease, a CTO, and in spider view can't see much. So in the still image, you can see that this chunk of calcium is a very eccentric, possibly nodular calcium in the distal left main, and these 2 aneurysmal segments here, and tight stenosis in the distal left main as well as the mid LAD. So indeed a challenging case, but good thing we had quite nice landing zones. So trouble started when we even started wiring. Starting wiring with a run-through floppy. Fortunately, after wiring, there was flow. But we see, you look closely on the second image, the wire actually got stuck. The wire got stuck. You can see how the EBU is so tightly dived in when I tried to pull back the wire. It probably got stuck in a crevice of calcium in the mid-LED, indicating the mid-lesion is probably even tighter than the distal left main. We actually tried to free the wire with a bit of ballooning, and fortunately we were able to free the wire. I couldn't capture that in time though. So after ballooning, there was flow. We put down the OCT, once again checking for flow, and we could see the flow, and this is the OCT of the vessel. So we got quite a good image, good run, and you can see from the distal part, here is the aneurysm, the big aneurysm, and just proximal to the aneurysm, there's a heavily calcified lesion. Here especially, there's a lot of irregular calcium, very deep, and probably a few dissections from the initial ballooning already. Let me just jump to the distal left main portion, which is here, and you can see all this very heavily nodular type of calcium. So analysis of the OCT run, we used the MLD max criteria, and this is the M morphology. Clearly it's calcific. And the second image here, this is actually the distal left main calcium, very irregular type of nodules all over the place. And good thing we had quite nice landing zone distally. We could analyze the diameter, both proximally and distally, and also the length, which was here. So we proceeded with rotational arthrectomy. We used a 1.5 burr. We didn't use a 1.25. I know it's very tight, but we were worried the 1.25 burr would increase the chances of burr entrapment. So we used a 1.5 from the get-go, and we were able to arthrectomize the lesion. So there was a lot of deceleration in the mid-LED part because the calcium was very, very heavy. So we actually modified the wire bias to achieve better rotablation by guide manipulation. So what we did was the EBU facing upwards, probably not such a good wire bias. So what we did is we tried to pull it up a bit, get a bit better wire bias. We thought of increasing to 1.75 burr, but the patient did have financial constraints, so we had to keep within the limits of finances. We also reduced the speed to 160,000 RPM to get better blur. So this is the repeat OCT. I'll just go through the still images. You can see this is a distal lesion before and after rotablation. There are cracks. And more importantly, very interesting to see, there's actually a huge bite in the proximal, the distal left main, where the rotablation was actually focused on initially. So we were quite happy, and we proceeded with balloon angioplasty. So you can see on the balloon with a scoring balloon 2, 5, and a 3.0, there's still a huge layer of calcium, a very long shelf of calcium, but we felt that we are not going to get anywhere by debulking that. So we just proceeded with stenting, and then the usual port and kiss, and this is the repeat OCT after stenting and optimization. So we came to our last challenge, which was the distal landing. You can see that we tried to land just nicely at the distal part, but it was sticking out a bit into the aneurysmal segment, into that sort of aneurysm. But the rest of the stent looked quite well open, well opposed, and especially if we jump to the distal left main part, which is here, the stent actually opens quite well. We stented to the ostium. There was no medial dissection. What only concern was the distal part. We had a discussion with a few panelists as well, and we decided to just leave it and not chase it too far. So this is our final results for that case. We didn't cause any perforations, and the stent opened quite well, and you can see that chunk of calcium has been whittled down to a small hill. So a few discussion points, any of us here in your country. Would your cardiothoracic surgeon and anesthetist an 88-year-old man, although he's fit, for urgent bypass in your center? Would anyone perform PCI to the left system first rather than the RCA? Do you routinely use backup transvenous pacing when performing arthrectomy to the RCA? And for the LMS LED lesion, would you have considered other modalities of preparation such as OAS, laser, IVL? Would anyone have upsized the rotabur to 1.75 or even 2.0 to get better debulking? And any other tips or tricks to optimize rotablation efficacy in calcified nodules, especially eccentrically calcified lesions? And would anyone use IBP upfront for this case prophylactically despite a good LVEF of 60%? And these are a few discussion points, and that's the conclusion. The patient recovered well post-angioplasty, was discharged home the next day. He was well at 1 month's follow-up in the clinic, and he's still fit, doing his routine cycling and gardening. So in conclusion, high-risk complex angioplasty can be successfully performed with low rates of complications when done with proper planning. And this case illustrates how intracoronary imaging by means of OCT has been instrumental in choosing the right calcium debulking methods, ensuring good stent expansion and reducing the risk of stent failure. In summary, I think intracoronary imaging should be mandated in cases with heavily calcified plaque. Thank you.
Thank you so much. Nice presentation.
Thank you.
Are there any comment or question from commentator?
Yes, thank you very much. Have to congratulations for your very nice and have a beautiful results of a very calcified regions. So back to your issue, I think 88 years old, and then normally I think in Asia will be refused by both surgeons and family.
Exactly.
Only if I think more than 80 years old and very fit, then we can persuade the surgeons to take the case. I think in our center maybe just one, two cases of over 80 years old that go for bypass. For the RCA, so we do not routinely put TPM for before the rota, but I think we prepare just puncture the venous, and then just in case that we can very quickly to put the TPM inside. Okay, so that's it. The others, let others.
Thank you for your comments.
Okay, thank you. Any comment?
Yeah, congratulations for the excellent case. I will agree with you that I will also start with the right side first, keep the burr as short as possible, trying to reduce the chance of having slow flow and transvenous pacing. But I would also like to place like a venous sheath and the arterial sheath 5 French over the femoral first, just in case if there is any hemodynamic instability, then we can put an IABP instead of upfront.
Yep.
So I will agree that I will keep it to 1.5 burr, because this patient we have to keep the flow to maintain his quality of life. We're not achieving excellent long-term result because this elderly octogenarian will probably need to improve his symptom only.
Yep.
So in my country, I think my surgeon will be very reluctant to take up this case as well. So, but in our country, we have the intravascular lithotripsy. So in that case, I think I would more prone to use IVL instead of upsizing the burr.
I understand.
Thank you.
Okay.
Thank you.
Thank you so much. Let's move on to the next presentation. Next presenter is Dr. Choi.
Yeah.
Okay, from Korea. Presentation title is Challenging Case Report, Chronic Total Occlusion Intervention in Heart Failure with Reduced Ejection Fraction Patient. So please.
Yeah, thank you for introducing me. Good morning, everyone. My name is Yeonjik Choi, and I'm from the Yeonpyeong St. Mary Hospital in Seoul, South Korea. I have been working at the intervention part since last year. Frankly speaking, my case is not complicated and severe as compared to other cases. However, at that time, I concerned about my cases as the beginner, so I prepared to share these cases with you. Yeah. My case topic is about CTO PCI in heart failure patient. This is my disclosure. A 44 years old male patient came to ER, and his chief complaint was abdominal distension and dyspnea. He was heavy alcoholic. He drank 4 to 5 times each week and 4 to 5 bottles of soju at one time. And he was the current smoker, 35 years. In chest X-ray, mild cardiomegaly. And in EKG, there was no specific findings except sinus tachycardia. And after I injected IV diuretics. His symptom was relieved and he wanted to go home, so he was discharged on medication. In outpatient clinic, I did Holter and TT. In Holter, there was no specific findings, APC and VPC. In TT, and there was severely decreased LV function. You have ejection fraction 18%, and diffuse global hypokinesia, and mild pulmonary hypertension, mild MR and TR. And in myocardial SPECT, the partially reversible ischemia at RCA and LAD territory were suspected, so I did coronary angiography. In LCA angiography, there was no specific findings in LCA, but as you know, there were collateral flows from LAD and circumflex artery to RCA. And in RCA, there was the CTO proximal to distal RCA. So at this moment, I wondered if it would be right to do the PCI and if the patient could endure it. Eventually, compared to the other coronary artery disease patients, he was young and his performance was not bad, so I decided to do PCI. After engagement using unplastic guiding catheter, I tried to wire passing through the region and using conventional BMW guide wire, but failed. The first image, I think, the first into the I success, but I think I saw that the wire into the fourth lumen. So I tried again using fine cross microcatheter and field XTA, but failed. So I changed to Gaia first, and I succeeded. So I did pre-ballooning Ikazuki and Celes range balloon, and I checked the IVC image. In IVC image, there were negative remodeling and much plaque burden. And after I checked the IVC image, I inserted the synergy stent. And in the follow-up angio and the IVUS, there were the residual stenosis and the stent under expansion, so I did adjuvant ballooning using finance balloon. And in final angiography, there was no complications, so I ended the PCI. This is the medications that I prescribed after PCI: DEPT and statin, ezetimibe, ILB beta blocker, mineralocorticoid antagonist, diuretics, deoxygen GA protector. After 6 months, I did follow-up TT, and his LV function was recovered from 18% to 55%, and the RVSP was decreased too. And this is the following drug medications that I maintained: DEPT and RNE, beta blocker, mineralocorticoid antagonist, and SGLT2 inhibitor, diuretics, statin, ezetimibe, evaporate, and GA protector. And next I'll show you a similar case shortly. A 50-year-old male patient came to ER due to dyspnea. He was diagnosed with asthma 30 years ago, and he thought that the cause of his dyspnea was asthma, but he visited to the ER because his dyspnea was deteriorated. And in chest X-ray, there was definite cardiomegaly. In EKG, there was no specific findings except sinus tachycardia. And at the time, I did the bedside TT, and I found severe decreased LV function. So I strongly recommend the hospitalization, but he stubbornly refused, and he wanted to go home. So he was discharged on medication, and I did in outpatient clinic Holter and TT. In Holter, there was no specific findings APC and VPC. In TT, there was severely global decreased LV function, ejection fraction 12%, diffuse global hypokinesia, and multiple hyperechoic thrombus at LV apex. So I did the coronary angiography to find out the cause of heart failure. In coronary angiography, there was chronic total occlusion of mid-LAD, mid-RCA, and the severe and diffuse stenosis at circumflex artery. And like the first case, I concerned about whether to proceed PCI. But I thought that it would be better to do PCI after application of enough heart failure medication, so I decided not to do PCI immediately. So the following drugs are currently maintained: ARNI, beta blocker, mineralocorticoid antagonist, SGLT2 inhibitor, diuretics, mono antiplatelet agent, statin, ezetimibe, ibarboradine, digoxin, warfarin, and GI protector. So the discussion point, yeah. I wonder what made the first patient heart function better. CTO intervention, heart failure medication, improvement of the patient's lifestyle. I think above all things have worked in combination. And I wonder what I should be careful about when doing PCI for severe heart failure, especially heart failure with reduced ejection fraction patient. Finally, I concerned about the appropriate time for second case patient. Yeah, final slide. In heart failure patient, especially heart failure with reduced ejection fraction patient, we have to proceed the PCI very carefully because heart failure, especially heart failure with reduced ejection fraction patients, are more likely to develop cardiac arrest and or other events during PCI than those who do not. Therefore, it is important to determine the PCI at the appropriate time. And finally, pre and post heart failure medication prescription are very important too. As I said at the beginning, my case is not complicated and severe compared to other cases, but I think it's very important to decide whether to do PCI immediately or after. And so I prepared to share my cases with you. Thank you for your attention.
Thank you for a nice presentation. I think these are very educational cases. May I ask a question?
Yeah.
Have you evaluated myocardial viability? Viability is very important in the case.
Yeah.
And in second case.
Second, actually, his compliance was very poor, so I recommend the myocardial SPECT, but he refused. So, and I planned the next step. Yeah.
Okay.
Thank you for the excellent cases. So, was there any intention or planning to use mechanical circulatory support for both of the cases? And assuming the second case, the LV thrombus is resolved,
I beg your pardon. Sorry. Yeah.
any plan for using mechanical circulatory support, like an
Mechanical
impeller,
support? But yeah, I think I thought that aspect, but his I think the PCI with mechanical support, but it's mechanical support using the PCI using the mechanical support is the itself it had the poor the prognosis and many other complications. So I did not want to use the mechanical support, and the patient did not want to. Yeah.
Thank you. Another question is, now with the revived trial published back in ESC this year, showing that multivessel PCI and heart failure reduced ejection fraction does not necessarily improve heart failure outcomes. With this data in mind, would you have approached these cases differently?
But I think in first case patient is the Sigenbert region is was RC, and in opposite the second case patient is the critical region in all three vessels, especially LAD. I believe the LAD is very, very important vessel. So I think to improve his heart function, I have to do the PCI, especially in LAD vessels. So I planned, second PCI, staged PCI. Yeah.
Thank you.
I have a question.
Yeah.
I have a simple question. In first case, he was the very heavy alcoholics.
Okay. Yeah.
In heavy alcoholics, the stop drinking is usually improvement of ejection fraction. I wonder, did he stop drinking anymore?
No. Yeah. He did not. He could not stop the tobacco and drinking. Not yet, but he has the decrease. Yeah, but he's not done yet. Yeah, stop done yet.
Okay, thank you so much. Let's move on to the next presentation. Okay, our third presenter is Dr. Frein from Australia. Presentation title is Challenging Case Report, Manage of the Wire Crossover Device and Crossover Heavy Classified RCA Region.
Good morning, everyone, and thanks for giving me the opportunity to present the case on behalf of my team at the Prince Charles Hospital. I have no disclosure. We have an 83-year-old gentleman with crescental angina. He had a background of heart failure with preserved ejection fraction, admission in 2021 with decompensated heart failure. COPD, ex-smoker, quit 25 years ago, but he had 55 PEG year history. Atrial fibrillation or NOAC, hypertension, hypothyroidism, and he's got moderate MR. We proceeded to coronary angiogram, which shows this is the left system. There was some calcifications in the mid LED, but there is no significant stenosis. On right coronary angiogram, there is a very tight stenosis in the proximal RCA and also calcium nodules in the mid, and there are two calcium nodules in the mid RCA. So he was attempted PCI by another operator, but wasn't successful and referred to our complex PCI program. We started with the femoral approach, 7 French AL 0.75. We used the 10 pi LP. The plan is to do the rotor ablation, 10 pi LP, but it was we had to use a lot of wires, feeder XDR, Gaia-second, XDA, on-it, and XD and XDR because the wire damage one across the calcified nodules. The proximal RCA lesion was crossed with the feeder XDA, and mid RCA was crossed with the feeder XTR. So the situation is wire crossable, but device uncrossable, even microcatheter. So we use the Sapphire, which is low profile balloon of 0.85 by 10, all the way from the proximal to the mid RCA, and then change to 10 pi spiral, which is to wedge at the mid RCA, which allows to change into the rotor wire. So we started with a rotor 1.5 bar. After 8 pulses, it crossed the proximal RCA lesion, and mid RCA lesion was crossed on 11 pass. He required pacing throughout the rotor ablation. We use the IVUS after rotor 1.5 bar, and you can see the napkin ring calcifications, and we still need to debug the lesions. So we proceeded with the rotor 2.0 bar all the way to the mid RCA, and it passed after a few passes. So this is the angiogram after 2.0 bar. So rotor wire drive was changed to the wiggle wire, which gives more support together with the AL075. We pre-dilate and with the NC35 by 12, and then we use the IVUS again. And then we put the drag eluting stent, 4x38 two stents from the mid-distal mid-RCA all the way to the prox RCA, and the post-dilate with the NC 4x15. This is the IVUS post-PCI. The stent is well expanded and no obvious malabsorption. This is the final result. So we left the mild to distal RCA lesions for medical management. So my discussion points are management of the wire crossable and device uncrossable lesion, and choice of the calcium modification tools, and use of intravascular imaging, IVUS or OCT in the calcified lesions. In conclusion, calcified coronary lesions are associated with adverse long and short-term outcomes, and management can be challenging. Meticulous lesion preparations with the calcium modification tools is essential to achieve the optimal results. And intravascular imaging is invaluable in assessing lesion severity, and which determine the choice of the calcium modification tools. And we can look at the effectiveness of the modification and deparking method, and optimizing the result of the PCI. Thank you.
Thank you for a nice presentation with severe calcification, very tough case.
Yeah, thank you.
Are there any comments from commentator?
Thank you for sharing a very complex RCA PCI. So no question regarding the technical issue. Just a question regarding your anti-platelet therapy, because your patient is AFib.
Yeah.
So how you plan to for the DEP therapy in hospital discharge and then for long term?
Yeah, so we normally do triple therapy for 1 month, and after that we stop the aspirin and clopidogrel and NOAC for a total of 12 months, and then NOAC after.
Okay, any comments?
I think for such eruptive calcified nodule or calcification cases, I would prefer to use OCT for better visualization of the coronary anatomy if the renal function is not a concern.
Yeah, that's right.
Okay, are there any comments from audience? Okay. Okay, thank you so much.
Thank you.
Yeah. Okay, let's move on to next case. The fourth presenter is Dr. Modi from India. Presentation title is a case of the calcified LAD with acute MY, primary PCI done with IVL. So please.
Thank you for introduction. I am presenting a case of calcified LAD in a patient of acute MI, and it was a subacute thrombosis. We did a primary PCI, and we used first time IVL in a patient of acute MI with clot. There are no disclosures. The patient was 69 years old, female. She was a diabetic, hypertensive. She was post-PCI. She already had 2 stents in the LAD. But this time she presented with acute ST elevation MI. Her ejection fraction was 20%. So this is the angiogram. You can see there was a long stent, 2 overlapping stents, and just at the junction, it was not properly expanded, and there was a clot formation where the two stents were overlapping. The angiography revealed subacute thrombosis in LNB, especially at the region where the stents was underexpanded and was overlapping. RCA was normal. So the left main was hooked with EBU 7 French catheter and crossed with a BMW wire. But we tried to do thrombosuction, but you can see the thrombostor was not able to cross the proximal portion of the stent. We changed the wire, so it might be through the struts, but nothing helped, and we stopped the idea to do thrombosuction. We sequentially dilated it with 2 into 12 millimeter balloon, and we tried to negotiate IVUS. Even the IVUS was unable to, we were unable to negotiate the IVUS also. So we decided to balloon dilate it first with 2 millimeter balloon sequentially from distal end to proximal end, then the area of under expansion, and you could see we could restore some of the flow after that. And this was the dilatation with the bigger balloon, that is 2.5, again starting from distal going up to the proximal end. And after the ballooning, you can see there was good flow, but still the clot was there in the distal part of the stent, and the overlapping portion still was underexpanded and looked like a nidus for future problems. So ultimately we could cross the IVUS. Then you could see there was overlapping underexpanded stent with a plaque burden of more than 50% there, and minimum area was still 7.3, but there was an underexpansion. The patient at the same time started having VT as there was a migration of the clot, which was settled with the IV Cardron, and we defibrillated the patient. And again, with a cutting balloon, we dilated it with 2.5 millimeter at high pressure, 10-12 millimeter, and again tried the thrombostor. Again, the thrombostor was not crossing. So we pre-dilated. Then we took a 3 millimeter balloon. Then we again pre-dilated with a very low pressure, because there was a clot distally. With a very low pressure, we just dilated the distal portion of this after the stent, and then sequentially proximal. Then we took an IVL because the stent was not expanding in spite of 3 millimeter balloon. We took an IVL of 3.5 millimeter into 12 millimeter, and 10 pulses. We expanded the whole the stent from distal to proximal portion, and it was our first experience when we were using IVL in a patient who had clot in the coronaries, and we found that the IVL did not break or migrated the clot, led to the migration of the clot, and it could effectively expand the balloon. This is you can see in the sync vein very clearly how this is the portion where the stent was under expanding. After the IVL pulses, you can see there was a difference in expansion of the balloon. So this was the comparison pre and post. You can see this was the before, and this was after optimization, and a good flow in the almost normal flow in the coronaries post. And then patient having recurrent VT and all these things. So we waited for a stipulated period for 3 months, and then patient was heart failure, having heart failure symptoms also. So a CRTD was done after a wait of about 3 months time. You can see there was a wide left bundle branch block also. No, it was, I think, CRTD was done. There was a wide left bundle branch block, and post CRTD, you can see there was narrowing of the complex, and the patient improved clinically also. So to conclude, underdeployed stents are a cause of subsequent subacute thrombosis, and imaging is an important tool to see the adequate deployment of the stent. The overlapping portion of the two stents should be minimal, as it could be a nidus for thrombus formation. This case illustrates that IVL can be used in a post-stent failure, and even when the patient have thrombus. This case illustration, we found the effect of IVL on thrombus was neutral, but we could use it safely. The Sync VN by Philips can be used to see the expansion of the IVL balloon very clearly. Thank you.
Thank you so much for very interesting case. I have no experience on the IVL. I don't know that IVL is effective for the thrombus.
In our case, we found it is not effective for thrombus, but this case illustrates that if a patient of acute MI have calcium and we want to use the IVL where the thrombus is present, so it will not have detrimental effect. We can use, like rotablator is difficult to use in a case of acute MI where there is a clot. So IVL can be safely applied in these patients. That's my idea of.
Okay, thank you.
Yeah.
Okay, any comments? Okay.
A question? Sorry. Go ahead.
It's your turn. It's your turn.
So I see you use a balloon beyond the stent when you see the clot.
Right.
But is there any concern because even when we use balloon with low pressure, then maybe you have a risk of
Yeah, that is
dissection?
okay, but this is a known technique. This is called I don't exactly remember, but this is a known technique. You dilate it just for 2 millimeter.
Okay.
This is a known technique actually. I have not devised it of my own.
Because
we use it when the clot migrates. We use it like a very low pressure, like 2 mm, 3 mm, just to. It will not cause dissection. Just getting 3 mm. That's all.
So any idea of just stop the procedure by that times and then just go a very aggressive anti-thrombotic because anyway we reestablish
We
the
tried
flow already.
to cross thrombustor so many times, but we never actually. But the best would have been suction. Actually, there was no doubt because the thrombus was migrating distally, but we couldn't do that. The only thing we could do was ballooning.
Okay.
That was the only option we had.
Have you considered options like intracoronary lytics?
The patient was too old, so I thought because already the patient was on GP2B, so putting her with such an old patient on thrombolytic, we did not had guts to do that.
Do you sometimes defer stenting in these cases if with medication and ballooning alone you are able to achieve a TIM?
Yeah, with medication was not a good idea because already the patient had 2 stents inside. So we wanted a clean result so that the good expansion as well as the stents should be clean of the this thrombus so that the future events don't occur. That was our idea.
I think if the original mechanism of stent under expansion was calcification, then IVL does do a good job in these tertiary IVL cases. I think there was another panelist, Dr. Zayed Ali, was supposed to be on this session. He from St. Francis, US. He published a nice paper on the use of IVL in stent under expansion due to calcification, which is a really good article.
Okay, please.
Yeah. In this case, that if I get right, in this case, cause of thrombus was stent under expansion.
Yeah.
then we have not used, IVL is not indicated for stent expansion. It is used only for calcification. And you have documented
I am telling you, I have a series of that. I have published in JEC also. We have used IVL in about 50 of the patients. The series is accepted and it is being published. We have used IVL in about 10 patients of underexpanded stents, which were please let me complete, which were underexpanded due to heavy calcification. So the stents were not expanding with the simple NC balloon, and even we have used cutting and scoring balloon in these patients, and that was not helpful. Ultimately, what we did was to do IVL in these patients, and we were successful in all the 10 of these patients. So in your practice also, if you find a underdeployed stent due to calcification, not yielding to the ballooning methods. And secondly, we use imaging in these cases. And from the imaging, we can guess that whether the patient will benefit from IVL or the patient will benefit from the other balloon therapies. The one important point in imaging is the thickness of the calcium. If the thickness of the calcium around is less than 100 micron, we can do away with the ballooning. If the thickness is more, we have to do some device like laser, rotational atherectomy, or IVL. Number one is the thickness. And the second point is circumferential. How much is the angle, thickness, and the length of the calcium? That we can determine by imaging, of course.
Okay, thank you so much.
Thank you.
Okay, let's move on then. Next presentation. Next presenter is Dr. Kim from Japanese hospital. Yeah. Presentation title is Developing Complex PCI, a Dilemma of the Calcified Bifurcation Staining. Okay, please.
Hi, good morning, everyone. First of all, I would like to thank the organizing committee for allowing me to share our case here today. I'm Dr. Kim Heng Shi from Malaysia, but currently attached in Okamura Memorial Hospital, Japan. My topic today is debunking complex PCI, the dilemma of calcified bifurcation stenting. I have nothing to disclose. So my patient is an 80-year-old man. His cardiovascular risk factor, he's a hypertension, ex-smoker, and family history of ischemic heart disease. He first presented to us with a CCS2 exertional angina. Physical examination wise is unremarkable. ECG was normal, echo showed a preserved LV function, and blood investigation was within normal limit. He then underwent a CT scan, showed a high calcium score of 545 with a high possibility of severe stenosis of LAD and moderate stenosis of osseous circumflex. This is his angiogram of RCA showing mild disease of PDA, while this one is a left coronary artery. As you can see here, there is a distal left main disease, severe calcification of the proximal LAD with a mid-LAD moderate disease. Osseous circumflex shows a severe disease of 90%, and we perform a FFR to the LAD shows 0.74. So we have a very elderly symptomatic patient. He has a preserved LV function. eGFR was 60. Lesion-wise, this is a Medina 111 lesion. Heavily calcified. Syntax 1 score was 30. Syntax 2 score suggestive for PCI. So after discussing your patient and the family member, they opted for PCI. So we have a complex coronary bifurcation here where we fulfill 2 major and 1 minor criteria as definition criteria. Well, I'm sure you agree with me, this is a cheap procedure if you are going for PCI with multiple comorbidities and a severe complex coronary artery disease that our patient have. So we started our case, I was gathered a cheap PCI, 8 French femoral artery access. Also, we secured a femoral vein as our vascular access. So we use a Roadmaster's 8 French with a side hole as our guiding catheter. Our plug modification we will decide after the IVUS assessment. Again, this is a baseline CAG during the PCI day showing a Medina 111 lesion. So this is an IVUS pullback of a left main LAD. As you can see here, is coming. Okay, so here is proximal LAD showing a circumferential calcified plaque with a serous stenosis. I can see this distal left main here. There is a moderate disease with heavy plaque burden. While this is a pullback from a left main circumflex, as you appreciate here, there's a severe disease over the austere circumflex and extending into the distal left main. So what we have now, we have a Medina 111 lesion, heavily calcified proximal LAD. There is a severe plaque burden over the austere circumflex extending into the distal left main. So first is what will be your lesion modification strategy, and how about your bifurcation strategy? For us, for this case, so we decided to do a rotational arthrectomy to the LAD. So we use a RotaPro 2.25 burr at a maximum speed of 220,000 RPM. We did 4 rounds of rotablation. So this is the IVUS post-rotablation. As you can see that there is a good calcium debulking with a fracture of a calcium ring, and there is a reverberation sign seen here. So what we have now, we have one less issue. We settled the LAD heavy calcified lesion. Then we are thinking to keep things simple. We thought that keeping things simple probably will be the best solution for our patient. So how if we can change a Medina 111 lesion to a Medina 010 lesion and perform an austere stenting LAD and DCB to left main circumflex, probably will be the easier way out. So we look into our toolbox. So what we found is DCA. We think directional arthrectomy is the answer to these challenges and questions. So with the use of a DCA, we can direct the DCA cutter to the area of interest where we can cut and remove the plaque and reduce the plaque burden. So our distal left main austere circumflex plaque modification strategy is use a directional arthrectomy. So what we are going to, our target of area of interest is the one that labeled with a red arrow, you can see here. So this is a distal left main and austere circumflex target. So we use a nipro-arthro cut L size 6 mm for 11 rounds, up to 3 atmosphere. As you can see here, this is the cutter with a balloon inflated. So this is some of the plaque that we managed to remove from our patient. Some of the plaque you can see here, all right? So on the left is a pre-DCA, and on the right is a post-DCA, showing a very good acute luminal gain. It's almost, looks like a normal coronary artery for us. Similarly, you can see here in the spider view. So this is the IVUS pullback of left main circumflex post-DCA, showing a very good debulking result with a very minimal residual stenosis. The MLA of austere circumflex improved from 2.23 to 10.42 millimeters square post-DCA. So we have settled a Medina 111 lesion and somehow converted it into Medina 010 lesion. So what we have now is from a complex bifurcation lesion to a non-complex bifurcation lesion. So to keep things simple, so our LAD, we perform an IVUS guided austere LAD stenting, and we perform a left main circumflex DCB. So we prepare the left main circumflex with NSC Advanced 3.5 13 scoring balloon at 60 atmosphere. There's a good balloon expansion you can see here, followed by applying a DCB sequence neo 3.5 15 at 8 atmosphere for 60 seconds. This is a post-DCB to left main circumflex showing a symmetry flow with no dissection seen. Then we perform an IVUS guided austere LAD stenting and use a Resolute Onyx 3.5 34 DES, post-dilated with a stent balloon. And on the left is the pre-PCI, and on the right is the post-PCI after applying a stent, austere LAD stenting and left main circumflex DCB. And this is a final angiogram. This is a finest IVUS pullback of a left main LAD. The left main MLA was 16.8, proximal LAD was 8.9, and proximal circumflex was 10.5 post-PCI. Here is the left main. All right. So this is our total procedure time is about 2 hours 15 minutes with a total contrast of 100 ml. He was discharged on second day post-procedure. And our discussion point is a long-term outcome of true bifurcation. Second is a dilemma of a bifurcation PCI, and the third is a contemporary DCA DCB strategy. Four, simple is the best strategy. So from Dr. Park's study, we know that the long-term outcome of true bifurcation PCI remain poor. And in our clinical setting, we know that frequently we encountered how to choose the best strategy for bifurcation PCI. Especially in the case of calcification bifurcation PCI. And we know that a complex left main bifurcation was associated with poorer long-term outcome compared to a simple left main bifurcation group. And the controversy of provisional versus dual stenting remained despite publication of EBC main and DK crush 5. So what we have now, we have a window for opportunity for simple is the best strategy. So we have a time-honored tool, DCA, directional coronary atherectomy. It was first established by Dr. Simpson in 1992. Unfortunately, it was stopped produced in 2008 due to the wide availability of a DES. But in Japan, it was reintroduced in 2014 under the name of ArthroCard by Nipro due to the demand from a Japanese cardiologist. So by using this DCA, DCB, somehow simpler bifurcation strategy and osteostenting, in our case here, we managed to reduce the step of 15 steps if you are using a DK crush in our case to just a 7 step. And we know that the more steps you have, the more chances of having complication or trouble. And this is a study by our Japanese colleague, show that post-DCA, DCB, there is a good improvement of MLD with a clinical outcome at 12 months of TLR of 3.1, TLF of 0.8, which is very good. And with this DCA, DCB strategy, there is no major procedure-related complication except some deep cut and slow flow phenomenon, which does not lead to severe complications. And we know that DCB work by time of contact to the coronary blood vessels and the amount of drug diffused in the coronary vessel, while DCA work by plaque reduction by cutting the plaque. So the combined use of DCA and DCB can prevent the carina and plaque shift and reduce the restenosis rate for coronary bifurcation lesion without using a stent. So we think that the combined use of DCA, DCB is complementary to each other. So in our center currently, if you have a large vessel bifurcation lesion, including a left main, we will, if it is suitable, we will attempt a DCA. And if there is a post-DCA, sufficient debulking without any severe dissection, we will use a DCA, DCB strategy, avoiding a stent. Else, then we will put in a DES. So in conclusion, the use of intravascular imaging allow the operator to properly understand the plaque distribution and the vessel anatomy, allowing us to choose the best debulking tool in a complex calcified bifurcation PCI. We demonstrated the supposedly two-stent bifurcation PCI can be turned into hybrid DES, DCB PCI with a good angiography and intravascular outcome with combination use of rotablation, DCA, and scoring balloon. And last but not least, we think that simple is always the best. This is our team in Okamura Memorial Hospital, leading by Dr. Fumitaka Hosaka. Thank you very much.
Thank you so much. A nice presentation with our combination use rotablator and DCA and DCB. Are there any comments from commentator?
Thank you for the very inspiring case. Do you have any interim results from these combined DCA, DCB use in left main bifurcation?
Actually, there is some small studies run by our Japan cardiology colleagues. So that show that actually, you can see that the one that I show, there is a 12-month TLR and TVF is quite acceptable. It's about 3%. We agree that we don't have a RCT result on this, and majority depends on the case registry and case series and some specialist opinion, expert opinion on this. So in Japan now, they are actually trying to collect data, and they are DCA come back again because we know that last time when they first introduced, because of we do not have a DES, there's a very high recoil and complication post DCA. But with the improved version of a DCA, actually it's much safer, but it's still a very technical demanding technology that need a steep learning curve on how to interpret which direction you are cutting. Cutting 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. So, but I think the controversy of bifurcation is always there. Austere ISI is always there. So we think with the use of this DCA, DCB, perhaps we have something newer for bifurcation.
Thank you.
Doctor, thank you.
Okay. So you stand the LED just as ostium.
Yes.
Okay. So any concerning of restenosis, because we all know that the ostium lesions always have a higher risk of restenosis, and then the second procedure will be difficult because you have a stand just as the ostium. Why you just stand from left main to LED, and then after that left main LED stand, and then DCB for left main circumflex?
Because if we, from the IVUS, it showed that the distal left main plaque is a majority is actually plaque extending into the osseous circumflex. So what we did is we did a DCA from the distal left main to the osseous circumflex. So we cut off the plaque and reduce the plaque burden. The MLA actually improved from 2 point something to a 15 post-procedure. So we think that it's actually good MLA. That's why we did perform an austere LAD stenting, avoiding stenting into the left main. So we are, some cases we do in our center, we even do a bifurcation DCB in this. We know that some operators do a bifurcation DCB, but with the use of DCA, actually you just debulk the plaque. So there's very minimal residual plaque, and then the mechanism of DCB perhaps will be maximize and optimal delivery of the drugs towards the target area. So that's the reason that we perform an osseous stenting and do a plaque modification from distal left main to the osseous circumflex.
Thank you.
Okay, thank you very much. Let's move on to the next, last presentation. Last presenter is Dr. Lim from Malaysia. Presentation title is interesting case, single vessel but calcified CTO with stenting across the left main.
Good morning. Thank you to the panelists and respected colleagues. Thank you for giving me the chance to present today. My title of this presentation is an interesting case, a single vessel disease, but a calcified CTO with stenting across the left main. My name is Benjamin Lim. I'm from representing Hospital Serdang in Malaysia. I have no disclosures for this presentation. My patient is Mr. HBH. He's a 68 years old gentleman, active smoker of 35 pack years with hypertension and dyslipidemia. He was referred from a district hospital due to an admission in August 2020. And he presented at that point with typical chest pain, diaphoresis, and was treated for a non-STEMI. Physical examination was unremarkable. ECG done at that point showed sinus rhythm, T-wave inversions over the anterior leads. His troponin level was 3.5 nanograms. And echo showed a normal ejection fraction, no regional wall motion abnormalities. His renal function was normal. When we look at the initial catheterization findings, we find that there's actually a short left main, a very calcified presence of calcification here over the LAD, osteal CTO, with collaterals from the right coronary artery and a relatively smooth circumflex artery. Another picture from the AP cranial view that you can see the calcification here, and a dominant RCA, which shows some mild disease over the mid segment here. So looking at his JCTO score, he has a blunt entry towards his CTO. There is some angiographic presence of calcification. Otherwise, there's no severe bending or actual, it's not a retry lesion, so total score is about 2. Now this is the images with a bilateral injection, and you can see the collaterals coming from the RCA and the track, calcified track here. We used an EBU 3.5, 7 French, over the left femoral, and also a JR 3.5 to the right radial. And we decided to PCI his LAD as the patient has come from quite a distance away from a district hospital. We used a Fielder XTA wire into a fine cross microcatheter And then we wire it to the distal LED and exchange to a cyan blue wire. We pre-dilated the LED with a semi-compliant balloon 2015. This is the image post pre-dilatation. As you can see, it's quite tight here after the 2.0. And we did an IVUS to get an idea of what we are dealing with, whether there's calcium. There were some fibrocalcific areas quite tight. And at the distal LED, you can see the MLA is about 4.1. The very tight segment at the mid LED was 2.87. The MLA at the proximal LED was 3.13. And also at the ostial LED, you can see a calcium chunk, and also the area is also quite small at 5.21. We decided to proceed with the rotablation to the LED with a 1.75 millimeter rotabur for 5 cycles at about up to 175 RPM. And we continued with further pre-dilatation with a NC balloon 3015 up to about 16 atmospheres of pressure. This is the image post NC balloon. And we decided to place a drug-eluting stent, a long one, all the way down from the mid to the distal LED, 2.5, 48 millimeters. Unfortunately, we didn't, because of the constraints of time and the volume of our patients, we didn't proceed with a second IVUS prior to that. And we deployed a stent there, followed with stenting to the proximal LED, as you can see here, and with the 3048, another long stent deployed there, and followed by ostial left main to LED, stenting 3.538 at 14 atmospheres. This is the image that we can see post-stenting. And we followed that with a further post-dilatation with the NC 3.5 over the proximal and also the ostial stents. And we post-dilated the proximal and ostial left main with a 4012 up to about 20 atmospheres. And you can see the image of the angiogram here after the post-dilatation. And when we look into the IVUS that we did towards the end of the procedure, we can see that the distal LED, the MSA now is about 5.7, 5.8 actually, and post-mid LED is about 8.1, which is much better compared to the 3.3, and 12.96 at the proximal LED. There's a slight step down here because of the calcification, 9.65 at the ostial LED, but in the left main, there's about 12.28 for the MSA. These are the images of the final angiogram. Another projection, the spider view. You can see there's no well-opposed stents, no dissection, good flow, TIMI3 flow down there. So in this patient, we actually used the CTO score. What would be your preferred method of evaluating a CTO? What would be your choice of for plaque modification between IVL, rotablator, orbital atherectomy, cutting or scoring balloons? In this patient, we decided for rotablation as pre-dilatation was done, making orbital atherectomy not very suitable, and IVL was not available at that point. So in conclusion, using intravascular imaging will aid in the planning, conducting, and optimizing PCI in heavily calcified vessels by aiding vessel sizing, length of disease, type of plaque, and suitable method of plaque modification and assessment of post-stenting complications and results. Adequate lesion preparation is key to successful PCI in heavily calcified vessels. Atherectomy, specialized balloons, for example, scoring or cutting or IVL, can all be used for plaque modification. Thank you.
Thank you for your nice presentation. Any comments from commentator? No. In Japan, we performed a cardiac CT before a PCI of CTO, and we check the distribution of the calcium and vessel size and occlusion length. So it is very useful for CTO PCI.
In my center, unfortunately, it's not routinely done. We don't really perform that because sometimes the patients come from about 100 kilometers away. So some of them come from quite far distances. So.
Okay. Any comments? Okay, time is over. Okay, thank you so much. I think it is a very interesting session and a very educational session. The session is now closed. Thank you for attending.